So good afternoon, I'm Maithili. I'm one of the doctors from Chelsea and Westminster Hospital in London, and I'm presenting the implementation of a multidisciplinary approach to care for people living with HIV aged over 80 years. I'm going to introduce our clinic, the methods we use to analyse the clinic and evaluate it, the demographics of our patients, outcomes from the clinic, and our conclusions. HIV care, as we all know, has evolved from a life-threatening illness to a chronic disease, and this success can be attributed partly to antiretroviral therapy. This has improved survival of individuals and has resulted in patients at risk of developing premature morbidity and other geriatric syndromes, including frailty. There's a growing body of literature looking at HIV and frailty, and one of the ways to assess this is using comprehensive geriatric assessments. So we implemented a multidisciplinary team consultations using a modified geriatric assessment. This involved either telephone consultations or in-person reviews when patients were admitted to hospital, or clinic reviews of patients. These were performed by a trainee in HIV medicine or a trainee in geriatric medicine. The patients then underwent a consultation with a specialist pharmacist. So this involved a thorough medication review, as well as looking at drug-drug interactions with their antiretrovirals, as well as drug-drug interactions within their co-medications. We also calculated the anticholinergic burden for each patient by calculating the anticholinergic burden for each drug and then tallying this up together. We assessed frailty using the Rockwood Clinical Frailty Scale, which is from 1 to 9, where 1 is a very fit, active person who exercises regularly, and 9 is someone who's bedbound and completely dependent for all their personal care. Based on these consultations, patients were either invited in for a further physical examination, which was tailored to the telephone consultation, or modifiables were then discussed with a full multidisciplinary team in clinic, and these were then liaised with their primary physicians and their community doctors. So we reviewed all patients aged over 80 in this dedicated clinic at Chelsea and Westminster Hospital and its other 6 peripheral clinics, which serves 13,000 people living with HIV between December 2022 and July 2023. We looked at the notes from the consultations, the pharmacy reconciliations, and the clinic discussions. This data was then inputted into Microsoft Excel, and descriptive statistics were performed. So our demographics. So we reviewed 63 people living with HIV. 72% of these consultations were over the telephone, 19% were in person, and 8% were virtual. The median age of individuals was 82, with most of our patients being male, 88%, with a median time from HIV diagnosis being 20.5 years. Most patients had an undetectable viral load, with 79% having a viral load less than 20 copies. A surprising finding was that the median clinical frailty score was 2. This is, for those who are not familiar with the Rockwood Clinical Frailty Scale, this is where they're active, but only at particular times of the year, so it's a seasonal activity. So we found that 5 individuals were completely dependent on personal care, and 4 of these individuals were housebound. However, it was surprising to note that only 2 individuals were in care homes. Found that 35% of individuals required a walking aid, and 23% of patients reported a fall within the last year. Looking at their other clinical parameters, the median number of comorbidities was 5, with the most common comorbidities being hypertension and cardiovascular disease. The median number of co-medications was 6, when polypharmacy was seen in 85% of individuals, and 41% of individuals were on more than 10 medications a day. We also looked at the anticholinergic burden, and in almost 10% of individuals, this anticholinergic burden score was greater than 4. We looked at different aspects of patients' health, looking at their memory, nutrition, and mood. 30% of individuals reported concerns regarding their memory. All patients underwent a 4AT assessment, and based on a combination of this test and their concerns regarding their memory, patients were either invited back into clinic for a further, more detailed review, or asked to be monitored by their primary physician in the community and for consideration of referral to memory services. 25% of individuals reported concerns regarding their nutrition, and this led to the diagnosis of a new anal cancer in one patient. With regards to mood and sleep, 30% of individuals reported some concerns regarding this. More than 3/4 of individuals had discussions related to advanced care plans, and this was a unique opportunity to discuss whether patients had a lasting power of attorney for their health and what their views on escalation of care if they were admitted to hospital and if they became unwell, what these would be, and their views regarding resuscitation. So the outcomes from our clinic. 75% of individuals had modifiables suggested that were not routinely performed by their primary care physician or their HIV specialist. 51% of individuals had investigations requested. These include specific blood tests such as hematinics, bone profiles, and vitamin D, or imaging such as DEXA scans or CT or MRI scans. From our clinic, based on our pharmacy discussions and reconciliations, almost 30% of patients had their antiretroviral therapy changed. So we tried to move away from protease inhibitors, which are often associated with side effects and interactions. And interestingly, 2 patients were switched to long-acting treatments and injectables based on their wishes and looking at the previous medications. With regards to co-medications, 62% of individuals had their co-medications reviewed and changed. And these were mainly antihypertensives, antidepressants, and analgesics. Almost 1/4 of individuals had referrals made to other members of the MDT. This was mainly to the physiotherapists and dietitians. And 17% of patients reviewed in our clinic were referred to other specialties. This includes dermatology, oncology, and geriatrics for a further future clinic review. With our antiretroviral treatments, we tried to reduce pill burden, modernize, and simplify patients' treatments. So before the clinic, the median number of antiretrovirals patients were taking were 2, and this after the clinic reduced to 1. So in conclusion, the majority of people living with HIV who were studied remain independent with a low clinical frailty score despite having multiple comorbidities and polypharmacy. It's important to note that this is not representative of all of those aging with HIV, but those who have made it to 80 years old. We found that medicine reconciliation is important to highlight polypharmacy and anticholinergic burden, which is often associated with cognitive impairment, falls, and death. Integrating comprehensive geriatric assessment into routine HIV care is important to identify frailty early and to put in place interventions to improve patients' quality of life. Our future work includes reviewing patients aged between 70 and 80 and seeing what their needs are, as well as looking at those who are living in care homes to identify their needs. I want to thank you all for the opportunity to present here today and for the rest of our team. Any questions?